As I talked about when I did that work about what people thought happened, and we showed, people really overestimated disability and underestimated survival. What we then had to obviously show people was what, both in the parent information sheets, but also, sorry, I'm just scrolling across on my second screen to grab this up, was to show, well, what happened to these babies? Because what we didn't want to see was more babies being actively managed at 22 or 23 weeks, but at this, with the result that we had more severely disabled survivors. So that was important. So it was important, therefore, that we looked at, well, what were the disability rates in our survivors? And we wanted to look at both what was happening here in Victoria and as well as looking internationally, because the numbers obviously in Victoria were small. So I will show you, let me just grab that up. Sorry, I'll just stop sharing for a minute. Just chat Alok for a sec while I just move that screen around. I'll just get that one. Okay. Just got my double screens running here at home, so I'll just, got that up now. So here in Victoria, we have a group called the Victorian Infant Collaborative Study, and this was set up by Lex Doyle took it over some time ago. Professor Jeannie Chong's now the convener of VICS, but was set up back in the 1970s, really by Bill Kitchen. And Bill was a neonatologist who realised the importance of not only providing intensive care for babies, but actually following them up into childhood to look at their outcomes. And so the VICS study is quite unique in that it has data from, we're now seeing 30-year-olds being assessed, followed up at 30 years of age. So similar to Epicure. They follow up children born extremely preterm or extremely low birth weight, so under 28 weeks, under a kilo. And this was the data. So these were children who were assessed at 8 years of age, so it's school age, and the children had also been seen at 2 years, but what we saw was looking at their outcomes at 2 years did not actually predict what they'd be like at 8. So as you can see, across the VICS cohorts, and this was a few of the VICS cohorts, only 7 babies were offered intensive care over those VICS cohorts, with just 2 survivors. One of the survivors was not assessed, so therefore we don't know whether in fact that child was severely disabled and that's why they didn't come for follow-up, or whether the baby was doing well, or whether they'd moved interstate. And one had major disability. 23 weekers, no major disability though in 67% of survivors, and in the 24-week babies in Victoria, no major disability in 75% of our 24-week babies. And so Jeannie's just published this recently in the Lancet Child and Adolescent Health, and we're just about to publish the data for the 2-year outcomes for our VICS cohort who were born in 2016, 2017. So I won't give away that secret yet, it's just about to be published. But of course, we were interested in looking at, well, what was happening around the world and how do we compare in Victoria to some of the other countries. So this was a very a recent meta-analysis published in Pediatrics, and this was looking at children from high-income countries who had been offered intensive care at 22, 23 and 24 weeks. And in this study, they looked at, the meta-analysis looked at survivors with severe impairment, and that was defined as children who had moderate to severe cerebral palsy, so unable to walk or walking with considerable difficulty, or with or without a walking aid, with a gross motor function classification system score of level 2 or greater, blindness, deafness, or an IQZ score less than 2 standard deviations relative to term-born controls. And always really important in any follow-up study that you have your term-born controls, because of course there is a proportion of term-born children who also have impairment. So all the VICS cohorts always have term-born controls in all of them. So what the meta-analysis showed was at 22 weeks, 36% of the 22-week babies were surviving with severe impairment, 22% of 23 weekers, and 19% of 24 weekers. If you flip that data around and actually look at these survivors who were free of impairment, I think this told a story that surprised some people, and that was that a quarter of the babies born at 22 weeks survived free of impairment. 35% of 23-weekers and 40% of 24. And so when we first did the parent information infographics, what we did was we put this together in a little infographic for the parents to help them sort of, to see if this was helpful for them in understanding outcomes. And so this is just from that meta-analysis. So this was the chances of disability in babies who were born at 22 weeks and survived. And for the parents, we described it as problems with intelligence, language, motor, vision, hearing, cerebral palsy. And as you can see, 24% no disability, 36% severe, and 40% mild or moderate. And so we're interested to see, well, how does that compare with babies born around all Australia and New Zealand? And we have an organisation called the Australian and New Zealand Neonatal Network, or the ANZNN. And this is a study that reports outcomes of babies admitted to all the NICUs across Australia and New Zealand, quite a rich data set. And they also follow up these children. So this was the data from our most recent ANZNN report. So the 2017 report, but for babies who were born across Australia and New Zealand between 2012 and 2015 and offered neonatal intensive care. And then these children were seen at 2 years of corrected age. So these were data for 74 surviving children born less than 24 weeks. So in the ANZNN reports, they pull the 22 and 23-week babies together because there are so few 22-week babies in Australia. But reassuringly, what we saw was, in fact, that 45% of these babies born less than 24 weeks were surviving with no disability. And that was, I think, a story that really surprised people. Just 30% of the babies had mild disability, 18% surviving with moderate disability, and just 9% of the babies surviving with severe disability. And when we looked at the same data again for the 24-week babies surviving in Australia, and this was for a much bigger number now, so 353 surviving children born in 2012 to 2015 who were assessed at 2 years of corrected age. Again, we saw that over half the babies at 24 weeks survived with no disability, 25% with mild, 14% with moderate, and 8% with severe. So it was painting a picture for us that perhaps was more promising than many people had previously thought, and certainly that outcomes had improved really substantially. Lex Doyle's just written a paper looking at the outcomes of babies in the VIX cohort who received magnesium sulfate compared with the previous VIX babies who had not received mag sulfate, and looking at the really significant reduction in cerebral palsy rates in the magnesium sulfate babies. So again, we're seeing some of those interventions that are really making a difference in terms of fetal neuroprotection.
Thank you. That was absolutely amazing. I mean, clearly a huge number of babies under, you know, a good cohort size showing actually mild to no disability amongst babies born at 22 and 23 weeks, albeit the 22-week population being slightly small. There's a really interesting paper that we circulated to our colleagues who are doing the module, which has been written by Genevieve Taylor, which actually looks at 2-year outcomes and correlates them with outcomes at 10 years. And actually a significant proportion of the cohort of babies at 2 years who had severe neurodevelopmental outcomes have mild or no impairment at 10 years of age. And, you know.
Yes. Yeah, and this is why it's so important. You know, children's Bailey's assessments at 2 years of corrected age do not reflect what these children are going to be like at school age. And this is why the VIC studies continue to follow up these children. So we've seen them, we've got our 8-year-olds, we've got a cohort that we've seen at 18, a cohort we've seen at 25, a cohort we're seeing at 30. The 30-year-olds, we're looking at their blood pressure, their lung function, their metabolic health, their bone health, really interesting, their mental health, really interesting follow-up of these children and seeing how much some of the disabilities that emerge into school age, like the attention deficit disorder, and that's been very fascinating within the group I work with, following the researchers who look at those outcomes.
Last question, because I know that we have to let you go, and I could keep asking questions from the participants, but one of the questions that one of my colleagues has asked is the importance of functional outcomes in counseling parents versus outcomes at 2 years, from the Baileys. Functional outcomes might be more relevant to a huge number of parents, and how do you address that?
Yeah. So obviously, and for those who joined us a little bit late, just to all disclosure, I'm a neonatal nurse, not an obstetrician, not a neonatologist. I work within long-term follow-up group, but what was interesting though, when we talked to the parents in the consumer advisory group, was that they weren't so much interested in those nuanced details.
Yep.
They wanted to know, will my child be happy? Will my child have friends? Will my child get married? Will they live an independent life? It was very interesting what was important to them, and it was more around, their kids being happy and fitting in and going to normal school, and not so much whether, specific details of what degree of functional handicap that they might have. And that came out really clearly from the parents, that in the end that was so important to them.
Thank you so much, Rose. I mean, today's session has been fantastic. I think, especially for our participants from the module, as well as from our Neonatal Network, we'd like to extend a big vote of thanks for, you giving us time on your weekend to speak to us on, I think, a topic that's very close to my heart, at least.
Yes,
and that, we've clearly had quite significant changes to our guidelines as well, which are gradually coming into practice. But I'd like to thank you. And obviously from our perspective, thank you from the Deanery as well as the network. Yeah.
Oh, thanks, Helen. And I'll send you a couple of papers around the various things we've talked about tonight, so you can put those on your Moodle or your LMS or whatever platform you've got. So I'll send those to you, and yeah, please, happy to share those with anyone. Yeah, and thanks again for the invite. I hope it's given everyone something, and bit of food for thought. And Alex got my email, but you know where to find me, so please don't hesitate to reach out or shoot me an email if you've got any further questions or comments. And thanks everyone so much for your time and your attention this morning. Yes, evening here in Melbourne. It's 9:30 on Friday night now. So yeah.
Thank you so much. We're extremely grateful. Thank you to all the participants.
Thank you. See ya. Bye. I'll just wait for them to all drop off there. Gradually all just leaving the room. Yeah, I wasn't, I'm just reading back in the questions now, some of that, yeah.
I didn't take the question on weight. I think the BAPM guidance talks of 350.
So Lex and I actually looked at when we did the regression analysis for mortality. The obstetricians were like, "What if the baby's really growth restricted? Can you put that in?" So we put in. What we did was we worked out from the birth weights, Z scores, 3 standard deviations from the mean, and said, "Okay, that can be a marker for severe growth restriction if their birth weight was 3 SDs." And so we threw that into the logistic regression model, and it didn't make any difference. So what mattered was outborn, with each decreasing week of gestational age, and with each 100 grams lower birth weight you were, didn't make any difference whether you're actually male or female in terms of mortality, or if you're a multiple. What mattered was birth weight, gestation, and where you were born, and that came out loud and clear every time. Yeah.
One question from my perspective, I mean, data for magnesium sulfate, at the moment, because in the UK, we've had quite poor coverage, I would say, until we've started, I think probably in the last 18 months picking up. But I mean, in terms of neurodevelopmental outcome data, it'd be lovely to get an idea from you of how much and how big a difference it's making at the moment.
Yeah, so Lex has just published that. So I've got the paper, I've got it sitting here in front of me. That was just published in, let me have a look where Lex published that. Very new, only just published like in the last couple of weeks. I'll just find it. I'm going to send all this to you, Alok.
That's really kind.
All these papers that might be of relevance. Here we go. So it's called Translating. It was published in the Australian and New Zealand Journal of Obstetrics and Gynae, which is a local, what am I trying to say, publication. 2021, so pretty new. And what Lex did was he looked at what proportion of live births who should have got it did, and then looked at, so overall cerebral palsy was in 6% of the survivors. Sorry, let me go back. Cerebral palsy was present in 4% of children exposed to MagSolve and in 13% of those not exposed. So an odds ratio of 0.28. I'll send you the paper.
That's really kind.
And he looked at what the uptake was, like what proportion of babies got magnesium sulfate. So sort of the pre and post, because we introduced it into clinical practice here in Australia in terms of our guidelines in 2010, I think it was. I'll have to have a look. I'm just trying to remember. Anyway, I've written it. We've got it in the paper. So we're looking at how many women actually got it.
Yep.
And not surprisingly, of course, outborns less likely. And inborns,
Thank you so much, Rose.
My pleasure. Look, I hope it sort of hit the mark. I know there was
100%.
I mean, but I thought for the neonatal fellows, they probably wanted a bit of data as well as.
No, I think that was perfect. I think it gives us a good flavor going forwards for the next talk that we're doing is actually going to be neurodevelopmental outcomes over the last 20 years. So, it sets the scene beautifully.
Right.
One last question.
Just finished, actually. We're writing, Lex has been asked to write a series for seminars in perinatology that's due out in November this year. And I've just written the paper on for that series on changes in survival and neurodevelopmental outcome over 30 years across the world. So, so that will come out.
With your permission, are you okay for me to share the papers with just the participants?
Absolutely.
That would be really kind.
Absolutely.